Good afternoon. I'd like to welcome and introduce Dr. Robert Murphy, Executive Director of the Havey Institute for Global Health and the John Philip Fair Professor of Infectious Diseases here at Northwestern's Feinberg School of Medicine, who answers your COVID questions every Wednesday on the Havey Institute for Global Health's Facebook page. Today, Dr. Murphy will be answering viewer-submitted questions and addressing the latest COVID headlines through today, the 24th of August. We invite you to submit your questions via Facebook at NU Institute for Global Health or by email at globalhealthinstitute@northwestern.edu. And leading the discussion today is myself, Sophie Bukowski, Student Research Assistant with the Institute. So Dr. Murphy, I'm going to start with some updated COVID statistics.
Great, Sophie.
In the United States yesterday, we saw 105,000 positive new cases, but our 7-day average is now hitting at 91,000 positive new cases, which is a 16% decrease over the last 7 days. Hospitalizations have decreased by 8%. The death rate in the United States has increased by 5%. And in Illinois, we saw 3,806 positive new cases yesterday, with our 7-day average at about 3,500 positive new cases per day. And there's been a 16% decrease in the last 14 days, with hospitalization and the death rate both decreasing in Illinois. Okay, what should we make of these statistics and where we are now with like the end of the wave that we're currently in? How would you decipher these statistics?
Well, we've been on the plateau now for about a month, and it looks like it is starting to go down. You know, all these waves we have, have a big uptick, plateau, and then down. Hopefully, we're on the way down. I mean, they all do that. So it's just a question of when. I think this one is staying more at the plateau stage because we've given up on all the mitigations. And, that will have a play here. We'll see what happens. I was in South Africa 2 months ago, and they were coming down from their peak, but they still had all the mitigations in place. I mean, if you were even walking outside, if you didn't have a mask on, you could actually get a ticket from a policeman.
Wow.
Yeah. So, I mean, they were very serious about it. And that peak came just really right down, and they have very few cases right now. So they're at the bottom. So we'll do the same, but it's going much slower, but it's going in the right direction.
Well, that's great to hear. And now for our first COVID headline. Everyone over the age of 12 is expected to be eligible for the new booster shot, the White House officials are now saying. So what can you tell us about how this will affect ages like 12 to 17?
Yeah, well, this is really good news and makes a lot of sense, because we can't just focus on the high-risk people with these vaccines. We really have to hit the whole population. Otherwise, this whole thing just keeps going and going and going. So now down to 12 is going to be eligible for these new boosters. They have half of the dosage is the new design against the Omicron variants, and the other half is the old version that people have been taking all along. So it's that mixture that's going to be given, and so this is really a good thing. In the interim, until that comes out, which is about another month or so, Moderna just filed their application, I think, in the last 24 hours. And Pfizer applied for theirs, I think, last week. And then it goes through the whole process of going through the advisory committees for the FDA and then the CDC. We have this cumbersome, crazy system. But anyway, it's already approved in the United Kingdom, the Moderna one. It should be approved here shortly. But anyway, it's coming. People still ask me, one of the most common questions is, should I wait for this new one to come out? I would say if you are at risk, I would take whatever you can get today. And then you're going to take this one in 4 or 5 months. So you're just delaying. The thing is, there's still a lot of COVID out there, and people are getting COVID like crazy. So if you're at risk, why wait? This not going to hurt you to get this second one, a couple months later. So it's a personal decision. I mean, I know people that have told me, oh, they want to wait for the second one. Okay, I mean, there's no real right or wrong, but I think I go along with the official guidance, which take whatever you can now if you're due for a booster, and then take the second version 2 booster, 4 or 5 months later.
Great. And now for our second big headline, which is that the FDA authorizes emergencies for the Novavax COVID vaccine for ages 12 to 17.
Yeah, so Novavax is already approved for for adults 18 and up. And it works just as good. It's made with it's made with an older technology. That doesn't mean it doesn't work. The technology is just fine. It's basically how many of our other vaccines are actually manufactured. These mRNA vaccines of Pfizer and Moderna are the new ones, this is great. They're down to the 12 to 17 range now. So it's just another option that people have if they want to take that vaccine, or that vaccine happens to be available. I think people should just know that it's effective and safe.
Great. And now for our third big headline, which the next two are for monkeypox. From dating to concerts, these activities aren't safe for monkeypox risk, experts are now saying. So what can you tell us about what's safe and what's not safe for monkeypox and prolonged contact, etc.?
Right. Yeah. These are all like very confusing words that are being misunderstood. Monkeypox is very different from COVID coronaviruses, which are spread, through respiratory secretions. So the monkeypox is spread really from direct physical contact. You have to have the monkeypox on one person's skin touch another person's skin. There's got to be physical contact. So if there is physical contact in a person who has monkeypox, particularly if the monkeypox area is exposed, that's high risk. And so how is that happening? It's happening during sex. Now, it's not a classic sexually transmitted infection, but if you have skin-to-skin contact, doesn't matter who your partner is, it could be anybody, male, female, otherwise, it really doesn't make any difference. It's the skin-to-skin contact. There have been a few cases where people were being tested for anal gonorrhea and with no lesions anywhere, and the cultures showed positive for monkeypox. So sometimes the lesions can be hidden in the body. So that could be in the mouth, or it could be in the anus, or it could just be, every little bump you have, every little skin bump, is not monkeypox, but some of them are. So, it's just touching. So just anything, I had a question earlier this morning, actually, a patient called me and said, oh, I'm supposed to be meeting with some family members, and no one involved in the story has monkeypox, but they're afraid, because they're a high risk group, that maybe they have it, and could they give it to these other people? And I said, you're having a family gathering, and I'm assuming that people are really not going to be doing too much touching, and nobody has a lesion, and it should be just fine. So compared to coronavirus, it's difficult to transmit, and that's a good thing. That's why we're talking about cases in the mid-teen thousands, 13,000, I think, something. I can't remember the exact number, but it's not like hundreds of thousands. I mean, we're having 100,000 cases of COVID per day. Right. It's a huge difference in the transmission.
Right. No, exactly. And our second big headline for monkeypox is that the Biden administration has asked for 1.8 million extra doses for monkeypox vaccine supply, as New York is urging for more aid. What can you tell us about what's going on, especially in New York, which has the biggest concentration of monkeypox?
Well, this is encouraging news that they haven't run out of money to buy this kind of stuff. This monkeypox thing is important to tamp down. And unfortunately, the way this is usually done is what they call ring vaccination. So like right now, there's a little outbreak in Congo, Democratic Republic of the Congo, for Ebola. So they just shipped 1,000 doses. Merck makes the vaccine for that, and to do the ring vaccination. So everybody around the person with it, anybody, any contact, family member, friend, close worker, something like that, they get vaccinated. That's called ring vaccination. With the monkeypox, that's not working because the people that are having the physical contact have had multiple partners and sometimes can't get a hold of those partners. So the ring vaccination strategy doesn't work. So you have to vaccinate the entire high-risk group. That's millions of doses. And so this buying another 1.8 million doses on top of what they already have is a great idea. Some 360,000 vials are available beginning next Monday, and then more are coming. Fortunately, this vaccine was already made and approved. It was approved for monkeypox. So we don't have to worry about, any of the regulatory hurdles and stuff is out there. It's just making the stuff, getting it out there, and getting people vaccinated. And then the caveat to that is if you give this particular vaccine, if you give it intradermally, so that's just right under the skin, where you use a little teeny needle and you inject 1/5 of the dose. You get a little bubble where you do the injection, and that's called an intradermal injection versus an intramuscular injection. And the intradermal injection actually results in a very nice immunologic response. So it has, because this is an emergency and there's not enough doses for everybody that wants the vaccine or needs the vaccine, people are recommending that. The problem with that is there's a lot of people, you have to be trained to do an intradermal injection, because if you give it accidentally below the skin in the subcutaneous tissue, it's probably not going to work at all. So you got to get it in. You have to do it right. It's a totally trainable thing to do. It's it's done for TB skin tests and the like, so it's not that difficult, but it does require some training. You just can't say, oh, give it intradermally if somebody's never given an intradermal injection before. So that's another whole thing going on that will triple or quintuple the number of doses that are out there.
Great. And now for our first and only COVID question. A few months ago, my brother-in-law got COVID. Per the CDC headlines, he was isolated for 5 days and then wore a mask when he was around others for the next 5 days. My wife and I had different takes on the mask wearing during the second 5 days. This individual presumed that an infected person is supposed to wear a mask to protect others, but would still be contagious. And this person's wife suggested that the infected person wears a mask to protect himself, so others, from others, so he doesn't experience a relapse. So which one is it, Dr. Murphy? Why is this individual wearing a mask?
Yeah, well, it brings up a lot of good points. But the reason the person is wearing the mask for day 6 through 10 is to protect other people, because that person can still be contagious. They're very unlikely to get a second COVID infection because their body's already revved up immunologically to fight COVID. That's probably that's not going to happen, basically. So you want to protect the other people. Now, these guidelines have been updated as recently as 2 weeks ago. And now they bring into the context of having a rapid antigen test. These are the tests you buy in the pharmacy. You can get them at a doctor's office too. They're the ones that the results are available in 15 minutes. I'm sure everybody's seen the little tube and the little pink lines on the white thing. It's almost like a pregnancy test. It looks like the results. Anyway, you can do that. It's actually day 6. They're supposed to come out of isolation, actually. And on day 6, if they have an antigen test and they repeat that 48 hours later, and it's still negative, so you have 2 negatives, they don't even have to wear a mask, because very few, if any, of those people with 2 negative antigen tests are contagious. Now, if you still have a positive antigen test, that doesn't mean that you're infectious, but you're more likely to be infectious. So approximately, one little study that was done in San Francisco a couple weeks ago, they report anyway, was that the people that still had a positive antigen test after 5 days, so on day 6 or later, they half of them had infectious virus in their secretions. So, you know, if you put that all together, if your test is negative, you're cool. If your test is positive, you're only half cool, maybe. So you need to wear your good mask for the rest of the 10 days. And remember, the first day of your symptoms, or if you were asymptomatic, the day of your first test, that's day 0. It's not day 1. So then you count from there. So that's the new guidelines. They're on the website. They're a little bit more clear than before, but it does throw in that caveat about the testing. So people can use the test to help them get in or out of isolation.
Right. Absolutely. Well, those were all of our COVID questions for today. We will see you next week, Dr. Murphy.
Okay. Thank
Thank
you.
you.